Now it is given to the other two gentlemen. So we have a 7-year-old boy with severe post-burn contracture neck with a fixed flexion deformity of the neck. He is posted for release of the contracture with a split skin grafting. Discuss the anesthetic management. Now, what are the challenges in this case?
Sir, there will be a neck contracture, sir. So there will be a difficult airway scenarios in this patient, sir.
Okay.
This is a pediatric.
It's a pediatric patient. Okay,
Yes, sir.
always look at the age. See whether it is a pediatric, normal adult or geriatric case. That is the first thing you have to say. So all the problems of pediatric anesthesia are here, and it is a anticipated difficult airway because the patient has a contracture with a fixed flexion. You cannot position the head for your conventional laryngoscopy and intubation. So the challenges are two things. One is pediatric patient. Second is anticipated difficult airway. What are the phases? Now, in any case of this post-burn contractures, the questions can be on two topics. One is entirely on how to manage the anesthesia for contracture release, or because again and again in a group of 10 students going for exam, the examiner may not like to ask the same question to all people. So he may suddenly ask all about the burn injury also, because it is given as a post-burn contracture, and burns management also comes under intensive care, and anesthetic role is very important. So questions can be asked on entire management of burns as well as management of anesthesia for this particular surgical procedure. So I have formulated questions to cover both these conditions. So let us see how it goes. What are the phases of burn injury?
There are three phases, sir. Ep phase, flow phase, and recovery phase, sir. The F phase is first 24 to 48 hours, and the flow phase is 48 to 72 hours, and the recovery phase is weeks to months after injury, sir.
Okay. So acute phase in the time of occurrence to first week, intermediate phase which is the healing period, and late phase where post-burn syphilis, scars and contractures can have. What you described as ebb and flow phase are coming under what is called the behavior or clinical scenario uh, classification. This is based on the timing of the burns. So in acute phase, from the time of injury to 1 week, then there is an intermediate phase. Patient may try to start heal or go in for complications like sepsis, AK and other things. And the late phases, most of the wounds are healed and then they start having a scar or a contracture. So that is one way of the classification of the phase. And what are the important points to be elicited in history taking in a patient with burns?
So the cause of burn, when it's a type of thermal burn, electrical burn, or chemical, and the timing of burn, when exactly, how much days duration, whether it's acute or chronic burn, where is the extent and site of the burn, how the depth of the burn, superficial or deep, and airway related, like history of hoarseness, rider related to airway.
Very good.
Either the history of inhalation or smoke exposure. Previously, any surgeries has been done, any SSDs or previous difficult intubation, previous history of tracheostomies, everything to be asked, and the medical comorbidities like anemia, malnutrition, repeated infection should be asked in the patients with burns.
Okay, very good. So
And
mode, source of sustaining burn injury, the first one. Initial severity of injury like airway involvement or burn shock, whether it is present. Treatment done during acute phase. How much of fluids were given? What are the pain management? What is the wound management? Time duration since the injury. Present disability. Any previous surgery and complications. So what is the first aid management to be done in an acute burn? The Supposing you see a patient who is having a burn in your house, what is the thing that you will do? Supposing
Sir, first
some
stop burning
old.
the burning process, sir. First stop the burning process, sir. Remove the patient from the source of heat, extinguish the flames, cool the burn, sir. Cool with running tap water for 20 to 30 minutes. Remove the objects like rings, watches, any tight clothing are there. Cover the burn wound. If there is airway and breathing, there is needed. We have to look for the signs, sir.
Okay, right. So classified as pre-hospital care and hospital care. Okay, first aid management can be classified as pre-hospital care and hospital care. In the pre-hospital care, minimize injury and save life by what is called stop, drop, or roll. Cool the wound. Okay? These are the four things: stop, drop, roll. Usually, you would have seen in all the movies. Immediately, you take a big blanket or rug and cover the patient and put them on the floor and roll them. That will prevent the fire burning continuously. It will stop burning, and once the fire is extinguished, then you look at the wound and start cooling the wound, as you rightly said, with a cold water. Then take care of oxygenation, triage the patient, and rapid transfer of serious patients. This is what is called the pre-hospital care. And coming to hospital care, it should be A, B, C, D, E, F, like airway, breathing, circulation, disability, exposure, and fluids. How are burns classified on the source? Already you have said that it will be thermal burn, it can be dry or wet, it can be electrical burn with the low tension or high tension electricity or lightning, or it can be chemical burn or radiation burns. So these are all the four sources of burns: thermal, electrical, chemical, and radiation. And what is the pathophysiology of burn injury? What happens when a patient sustains a burn?
So different systems has different
First,
reactions, sir.
simply, supposing when your body is exposed to a burn injury, what are all the changes that happen? I'm not asking about system-wise change, that we are going to discuss a little later.
Physiology, sir.
But every tissue, how is it affected? What are all the basic changes that happen in the various tissues that are exposed?
Classified into three zones, sir. Zones of coagulation, based on the concentric zones, the zones of coagulation, zones of stasis, and the zone of hyperemia, sir. So
that is histological. What you say is you cannot see it with the naked eye. It is the histological. Is there any name for that description? Zone of coagulation, zone of stasis, and zone of hyperemia, what you described, which are seen mostly under microscope.
Okay, sir.
Who described that? Jackson's model.
It
is called the Jackson's model. Very good. So, but what happens normally is major burns produce massive tissue destruction. Immediately, there is a cytokine-mediated inflammatory response from the injury site as well as distant sites. Okay? Then systemic the effects occur in two distant phases. That is the burn shock, which is called the F phase. So this description of phase is mainly for pathophysiology. Okay? Earlier, what I said is the acute, intermediate, and late phases are for the timing of phases where you can interfere at various levels. Then the second phase is called the hypermetabolic or flow phase. And this was described by Cuthbertson in 1942. And the various changes that happened are described in this flow chart. So once there's a burn, major problem is because of the inflammatory mediator release like histamine, bradykinin, serotonin. The other thing is microvascular changes that happen. So vascular changes and inflammatory changes are the two major causative factors for all the problems or pathophysiology that happen. So once the inflammatory process comes, there is a systemic inflammatory response, which also affects the microvascular system. So there is increased vascular permeability, increased hydrostatic microvascular pressure. This leads to increased extracellular fluid, decrease in intravascular fluid. So patient, this burn hypovolemia is described as patient bleeding into his own tissues. There is no overt blood loss like as in a trauma, where there is a vessel is cut and you lose all your blood and become exsanguinated and hypovolemic. Unlike that, in burn injury, patient bleeds into his own compartments. From the intravascular compartment, the fluids escape out into the interstitial and extracellular fluid. So there is a edema occurring in the tissues. So intravascular volume gets depleted. There is hemoconcentration, and there are hemodynamic changes. The first few 24 hours, which is the F phase, there is a because of the decreased cardiac output, there is increased systemic vascular resistance, increase in the catecholamine release, and try to correct that hypovolemia to maintain the blood pressure. And this leads to hypovolemic shock, and the inflammatory response also affects the cellular mitochondrial function, which is called the cellular shock. So both of them combined together produce the so-called burn shock. So the goal is to restore tissue perfusion. That is the ultimate goal in this. So these two descriptions, inflammatory response and microvascular response, leading to hypovolemia and hypovolemic shock, as well as cellular shock leading to what is called the burn shock. This is the pathophysiology that you have to describe. And describe the effect of burns on various systems. This is where you can describe about each and every system. What is the effect on cardiovascular system?
So there will be in acute phase, there will be a hypovolemia, sir. There will be increased capillary leak, plasma leak into protein. There will be decreased intravascular volume. There will be decreased cardiac output. There will be increased systemic vascular resistance. There will be hypotension in the early phases, sir.
The late phase,
See whether it is correct. So can be systemic, serious, vascular, RS changes, Planck vasospasm, and effects on fluid therapy. All these things have to be described. And it can also produce systemic inflammatory response and hypermetabolic phase changes, which is the second phase. So if you see the cardiovascular, hypovolemia, myocardial depression, decreased cardiac output, and burn shock can happen up to 48 hours. Vascular effect, there will be increased permeability, sodium and protein leak into interstitium, tissue edema is happening. The respiratory system, you can have bronchoconstriction, ARDS, and peripheral splanchnic vasoconstriction produces renal perfusion, may result in acute kidney injury, ileus and stress ulceration, and the effects of fluid therapy. Over fluid resuscitation or aggressive fluid resuscitation can lead to tissue edema, pulmonary edema, and abdominal compartment syndrome. And systemic inflammatory response increases the HPA axis and increases in ADH, sympathetic nervous system activation, and renin-angiotensin aldosterone activation, hypercoagulability, and albumin loss will be there. And the hypermetabolic phase after 48 hours and go on up to 1 year in major burns with increase in catecholamine, cortisol, and glucagon, decrease in insulin, so they may have hyperglycemia, increase in hepatic gluconeogenesis, and alteration in glucose metabolism, hyperdynamic circulation, hyperthermia, increased oxygen consumption, weight loss, muscle weakness, immunosuppression, impaired wound healing. So these are all the changes in the various system. What is the definition of a major burn? This is a very common question they may ask you. How do you define a major burn? Which are all considered a major burn?
Sir, based on the body surface area burnt and the area of the body burnt, sir.
Location, very good. So
30.
it can be major burns are defined on the basis of thickness and extent. It can be full thickness of more than 10% or partial thickness more than 20%, or in the extremes of age, even if it is at 10%, and patient with more than 25% in adults. All these things are considered as major burns based on the thickness and extent. Then the second is depending upon the site involved. Any burns happening in the face, hands, feet, genitalia, perineum, and major joints, they are all considered as major burns, irrespective of the thickness or if it is on the percentage. These are the two ways you classify major burns. One is on the thickness and extent, second is on the location or site involved. And third, if there are inhalational injuries, that also considered as a major burn. And if it is caused by the chemical, then it is considered as a major burn. Electrical burn also is considered as a major burn. Why electrical burn is also considered major burn? What is that? What is the mechanism of electrical burn? Electrical burns have a site of entry and site of exit. When you touch a live wire, whether it is a low tension wire or a high tension wire, the part which comes in contact with the current at the wire, that is called the point of entry or wound of entry. And this will be always tried to be grounded. So it will travel through your body and go out of your body towards the earth surface, and it will exit. That is called the wound of exit. And one wretched thing about this electrical burn is it will manifest slowly. Today it may look like if you have touched with a hand and if your palm alone has got a visible wound and you think it is only 5% or 3%. Gradually what will happen next day, it will spread to the dorsum, it will spread to the forearm, it will go to the arm. So like that, day by day, the tissue necrosis will go on increase, and it may take up to a week to become delimited. So that is the major problem with electrical source of burn. That is why it is included as major burn. And by patients who have comorbidities like diabetes or renal disease or cardiac disease, they are all considered, if they develop a burn, that is considered a major burn. And burns associated with other trauma, polytrauma patients, for example, a bus catching fire and also going on a head-on collision with another vehicle. Patient may suffer multiple fractures as well as burn injuries. So that also is considered as a major burn. So these are all the various categories which are considered a major burn. What is the role of anesthesiologists in various stages of burn?
The first stage of burn is very difficult to operate, sir. It's a very hemodynamic catastrophic. So normally
No, here, please listen. This classification first I told you about the acute, intermediate, and late phases. Or it should have been actually worded as stages rather than phases because that will cause confusion with the earth phase and flow phase. I should have worded it as stages. So the acute stage, intermediate stage, and late stage. Supposing you happen to go in a trauma team to the site of burn accident, a fire accident site. What is your role there? What are all the things you can do in that site?
In acute stage, the ABCDEF is the goal, sir.
Airway
No, I'm
maintenance.
asking you about your role in the field where there is a fire has happened and you are going in the team of doctors who go to rescue the victims in a fire burnt accident site. You are there in the team. Now, what are all the ways you can help the people who have got it fire?
Yes, sir. With the airway maintenance, sir. In case the patient is
Very good.
in case required for ventilation or intubation, we can help in that way, sir.
Okay, very good. Then
Circulation, sir. For
You can hemodynamic stability. You can start an IV there itself, because nowadays you have ambulance, you have every facility there, so you can start IV resuscitation. Very good. Can you give pain relief in the field?
Sir, in case of any blocks are required, or ketamine or anything, opioids
You
or
don't
anything.
have time for blocks, but you can use ketamine. Okay, so extrication of patients who are caught under debris or who have suffered a fracture along with the burns. So during acute phase, initial resuscitation, securing airway, IV access, pain relief, fluid therapy. All these things can be done by the anesthesiologist. During the intermediate phase, that is after you have shifted the patient from the site of injury to the hospital, you can look after them in the ICU care, you can manage the antibiotics, then take care of the nutrition. Then you can give anesthesia for that is dead tissue, necrotic tissue excision, wound dressing and grafting. All these things you can do. And during the late phase or late stages, you can give anesthesia for contracture release or reconstructive procedures. Okay, so this is the role. What are the functions of epidermis and dermis? The skin is the most important organ which gets involved in most of the burns. So you must know something about the role of skin in our body. So what is the function of epidermis and dermis?
Sir, the main it's a protective layer, sir, and it has a sensory, thermoregulatory, and
Both are protective layer, and the dermis is the protective layer.
So the dermis is
Epidermis is a protective layer, sir.
protective mechanical
Epi means upon, so it is above the dermis. So epidermis is the most important protective layer. How does it protect?
So it acts as a protective barrier against microorganisms.
Microorganisms. Does it have an immune function also? Apart from a physical barrier, does it have any immune function?
It prevents fluid and electrolyte loss, sir. It prevents excessive heat loss.
So this picture will tell you. So epidermis prevents fluid loss, barrier to entry of microorganisms, major site of immune system activity, neurosensory pain, touch sensation is from the epidermis, social and psychological. The color, the texture of the skin, all these things produce a social and psychological effect on the patient. And the dermis, which is lower down to epidermis, regulation of body temperature, then dermal vascular fluxes are present in the dermis, sweating and piloerection, the hair follicle and the sebaceous glands and sweat glands are all present in the dermis and responsible for skin durability and flexibility. So this only, as age advances, this dermal portion will be lost, and that is why you get wrinkles in the skin becomes more friable and easily breaks down. All these things happen because of the change in this dermis. So these are all the functions. So you have 5 functions for epidermis: prevents fluid loss, barrier for entry of a microorganism, immune function is also there, sensation is there, and gives a psychological and social cover. Then for dermis, you have the regulation of body temperature, then responsible for skin durability and flexibility. It is the area where you get the sweat glands and piloerection or hair follicles. What are the structures structures of the skin involved in various thickness of burns? Or how do you classify the depth of burns?
Yes, sir. We can classify them as superficial, sir, and partial. And in partial, we can classify them into superficial and deep partial. And the third one is full thickness burn, sir. So in one superficial, only the epidermis will be damaged, and in superficial partial, the epidermis will be damaged, and along with the upper 1/3 of the dermis. But usually the hair follicles and sweat glands are preserved. And in the deep partial, the dermis and almost most of the epidermis and the most part of the dermis, along with the hair follicles and
Sweat glands, sebaceous glands, all will be lost.
Be destroyed.
So
And it
these
will
are all
be
the three phases.
bone and
So what is Jackson-Burn model? Already we have seen. This is the central zone of coagulation, followed by zone of stasis and phase of hyperemia. So is this model used elsewhere in any other injury apart from burns? This three-zone model of central area of coagulation, followed by zone of stasis and followed by zone of hyperemia, is it followed in any other injury to any other organ in our body?
so brain.
Is there a different name for that? Head injury, how do you describe the head injury?
This in cerebral ischemia or stroke, we can be used as it.
So what is the name for that zone of stasis?
Sir,
In
core
head injury.
core infract area, outer ischemic penumbra and
It is the
all
penumbra.
ischemia, sir.
Okay, so this central zone of coagulation, which is also described in head injury, it is a dead tissue. It cannot be revived. Whereas the second area, which is the zone of stasis, is neither fully dead nor fully viable. So this is the zone which you have to retrieve and get back to your original vascularity. Otherwise, the loss of this area will cause what is called the secondary brain injury. So brain injury is, all of you would have known, is classified into primary injury and secondary injury. The secondary injury is nothing but the extension of this zone, second zone, which also becomes coagulated or necrotic, and that is the further damage that is happening. Okay, so the same model is used in head injury also, by the way. And these are all the again various zones that are there. So cells viable but not vulnerable, but vulnerable. Still they can become completely dead. This hyperemia is expected to completely recover. To identify the depth in the following burn phase, I am showing photographs.
First degree burn, sir.
This is called the superficial or first degree burn. Very good. Only redness is present. There is no blister or no other damage seen. This.
Second degree burn, sir.
It's a combination, superficial and deep. Okay? Both superficial, redness is there, as well as deep dark changes are there. So this is a third degree burn. This is
deep partial second
this
degree.
is superficial partial or second degree burn. You can see the blisters happening in this. So this is called the second degree burn. This one,
Third degree burn, sir.
this is a full thickness burn. Okay? Fourth degree or full thickness burn, where you can see a lot of scar formation. The patient is already. So how is the rough estimation of extent of burn done?
So can be done through the rule of 9, sir.
The question
Where
is
is rule
rough
of-
estimation. It is not an accurate estimation. I'm asking. Rule of 9 is more accurate and precise. Whereas rough estimation in an emergency,
Palmar surface. We can use palmar
yes, you
surface.
can use the Palmar surface. Patient's palm is equal to 1% of the patient's total body surface area. So quick method, it burns up to 15%. You can use this by measuring with his own palm. What is the formula used to assess the extent of burns in adults and older children? This is where you said about the Wallace rule of 9.
Of
Okay?
9, sir.
So that comes for exact extent of burns, you can say, and all of you are familiar with that. So head and neck, whereas in older children, it is head surface is bigger. So see, head front is 18%, back is 18%, and whereas the leg surface is smaller. And in adult, it is all multiples of 9 and multiples of 9. What is Lund-Browder burn diagram? Where is it used?
Sir, it
classified according to the depth of the injury, sir. It assessment in the wound care and predicting the functional and cosmetic results, sir.
Okay. So this is a diagram which can be used for both adults and children. Okay. And, this is the Lundberg chart which is used, so you can exactly mention the location or site of injury as well as the percentage. Okay. So this was first introduced in 1942, the basis of what is today's estimate burn size of people of all ages, and defines 12 anatomical regions with defined lines of demarcation, as well as introduced the age correlation factor for children of different ages also. And are these methods applicable to morbidly obese patients?
No, sir.
No. So morbidly obese patients, this Wallace rule of 9 as well as Lund-Browder is not possible. So you use what is called rule of 7 for estimating burn in individuals with more than 30 kg of BMI. So here it is head 2%, arm 7%, back 28%, leg 14%. So it is all multiples of 7 except the head. Okay, so this is what is applied for obese patients. What is Mercy Burns app? Right, if you have not heard about it, it's an app which can be used with a smartphone or tablet application and aids in the assessment of percentage of total body area and also calculation of fluid resuscitation protocol. Okay, this was the app calculates the TBSA using the Lund and Browder method and resuscitation fluids using the Parkland formula and background fluids for children. And this was created by Chris Seaton, formerly a captain in Royal Army Medical Corps, who created easy-to-use iPhone or iPad application after seeing the horrific injuries burns caused to fellow soldiers. So on a touchscreen phone, the user simply colors the sufferer's burnt area on a computer model of torso and adds in the patient's age and weight, estimated, not exactly known, and the precise amounts of fluids are initially calculated. So you can see this is how you can use the place. Supposing this is the portion which is burnt, you just focus your camera on that and apply a color to that. It will immediately calculate the percentage and give you the percentage as well as the amount of fluid to be injected. What are the causes of respiratory injuries in burns and how are they classified and what is their importance? As an anesthesiologist, how will you have to be careful about a patient brought to emergency with a closed loop fire and he has inhaled the fumes and he has developed a respiratory burn also. So how are you going to classify the respiratory burns?
So the respiratory burns can be of thermal, chemical, or toxic effects, sir. In thermal injury, it can be of cause of hot air, steam, or flames, sir. It may be very common in the house fires, industrial fires, sir. Mainly affect the upper nose, oropharynx, and larynx, sir. Smoke inhalation is most common, sir. It is contents of soot, particles, matter, irritant gases, sir. It causes bronchospasm, chemical pneumonitis, and impaired mucociliary.
So that comes under lower airway or upper airway?
Lower airway, sir.
So you can classify them as upper airway burns and lower airway burns, or results of upper airway injury and lower airway injury. Okay. So this is how you classify. The larynx, it can be caused by hot air or steam. Effect will be laryngeal obstruction or laryngospasm actually, or then At the trachea level, smoke and hard particles, mucosal sloughing, infection, bronchiolar plugging, atelectasis, and bronchospasm. Lower airway, irritant gases producing pneumonia, pulmonary edema, alveolar capillary deficit, etc. And the warning signs are patients may have injury or burns around the neck and face. History of being trapped in a building with closed wound. Patient may have change in voice, stridor, shoot in sputum, respiratory distress. And if airway edema is suspected, immediate intubation must be carried out. Otherwise, the mucosal edema will rapidly increase and you cannot intubate with an adequate size tube, especially in adults. You may have to use a very small size tube. So what is the danger of using a 5 size or a 5.5 size for an adult?
Increased airway resistance will be there, sir.
It will cause negative pressure pulmonary edema because of the increased resistance. Okay. And so you can classify the airway burns into above the larynx and below the larynx. So above the larynx, direct injury to nose, mouth, tongue, palate, larynx, etc. Saturated vapors more injurious. Upper airway edema peak within 24 hours, subside after first week. Whereas below the larynx, better heat exchanger mechanisms. Steam can cause loss of respiratory epithelium and form cash and mostly pneumonia and pulmonary edema and alveolar capillary deficit will happen. What are the other injuries to be looked for in closed space fire and how are they diagnosed?
So smoke inhalation, sir.
Smoke inhalation, what is the component which can be very dangerous?
So the irritant gas, soot, particle matters.
Carbon monoxide, sir.
Carbon monoxide. First and foremost is carbon monoxide poisoning. Okay, that is the most important thing you have to write in the exam. If it is asked in the theory or in the viva also. So features of carbon monoxide poisoning are nausea, vomiting, headache, hypotension. And if you check the ODC curve, it will be shifted to the left. And carbon monoxide, because it has got 250 times greater affinity to hemoglobin than oxygen, and pulse oximetry overestimates the saturation. And co-oximeter can detect the presence of carboxyhemoglobin. And the treatment is by 100% oxygen or hyperbaric oxygen in severe cases. This is the first thing. Second is the cyanide poisoning. It binds to the ferric ion in cytochrome A enzyme, produces severe lactic acidosis. So how to manage airway in burns? What are the indications for early intubation?
Sir, management is in case if you are suspecting any airway burns, then it's better to ventilate the patient, sir. Early indications are.
Already we have given the answer. It is an upper airway edema. You have to intubate, but the management is initial management of inhalation injury, propped up position 30 to 90 degrees, high flow humidified oxygen, bronchodilators and physiotherapy, fiber optic bronchoscopy in intubated cases, better diagnosis and enables pulmonary toileting also. Okay. So these are all the various gadgets which can be used depending upon whether you are able to intubate or whether you have to go for a surgical access. And these are all the various indications. Early intubation is considered in the presence of a stridor or GCS less than 8, hypoxia or hypercapnia, full thickness burns around the neck which may start constricting the neck, deep facial burns, oropharyngeal edema, total body surface area more than 40%, which may result in massive fatty edema following fluid resuscitation. Okay. So these are all the indications for early intubation in burns. Presence of stridor, lower GCS, hypoxia, hypercapnia, full thickness around neck, facial burns, oropharyngeal edema, and major burns with more than 40% of total body surface area. What are the effects of burns on renal and gastrointestinal tract?
Sir, in
in renal system, there will be
They
decrease
prone
in
for
GFR and oliguria
AKI.
in the acute phase, sir.
for a hypovolemia, sir.
Yeah,
So
mainly because of hypovolemia. Okay, renal hypovolemia causes decreased cardiac output, decreases renal blood flow, decreases GFR, decreases urine output. Okay, so
Yes, sir.
mainly because of hypovolemia, and this will activate the RAS system, which will cause sodium and water retention and loss of potassium, magnesium, and calcium. And if there is a lot of full thickness burn with muscle injury, it may cause myoglobinuria, which may again cause mechanical blockage at the tubular level, sepsis-related nephrotoxicity. You can have AKI. They can go for hyperkalemia due to tissue necrosis. And in the GIT, ischemia due to inflammatory and microvascular changes. The primary two changes that we saw in the pathophysiology, which will cause stress ulcer, gastric dilatation, paralytic ileus, abdominal compartment syndrome, acute pancreatitis, or acalculous cholecystitis. So, how is fluid replacement done for burns patients? This is a very important question they may ask you. What are the formula that you can use?
Sir,
Mainly use this Parkland's formula, sir. So
the first 24 hours, we can give 4 ml times the body weight times the total body surface area burn, sir. So, Ringer's lactate we can use, and half of the total volume should be replaced in 8 hours, and the next half should be given in the next 16 hours, sir.
What does that first 8 hours mean? Is it from the time of injury or at the time of arrival at the hospital?
from the time of burn, sir.
So that is very important. For example, if a patient is transported from a rural area and he arrives 6 hours after injury, so the first 8 hours does not start from the arrival at the hospital. It starts from the time of injury. So within that next 2 hours, you have to give the half. So that is a very important thing that everybody has to remember. So modified Brook formula is the one which is preferred over Parkland, which is a higher volume, which
Yes, sir.
has
It's a 2
resulted
ml
in
per
more
kg
tissue edema.
plus.
Pardon?
Yes, sir. It's 2 ml per kg into total surface body water.
That is for modified Brook. Parkland is 4 ml.
Yes, sir.
Okay, and you give lactated ringer first half, first 8 hours, next in 16 hours, and it's a starting point which may need adjustment based on the urine output. So the main target is producing at least 0.5 ml per kg of this fluid, I mean urine output. And Parkland is 4 ml per kg, recommends crystalloids to combat burn shock, but requires careful monitoring as volume overload can happen. And what is the rule of 10 formula in fluid management in burns? These are the two commonly used formulae, but there is another formula called rule of 10, which is used in an emergency situation.
So it's a simple bedside method, sir. We can calculate for first 24 hours, sir.
It is not for 24 hours. It is for the emergency fluid management in the site of injury or acute phase. Okay, when you don't have time for calculation and all that. It's a burn quick estimation method for starting IV fluids in adults with significant burns more than 20%, where the total body surface area is rounded to the nearest 10%. For example, if you have 26% burns, you make it 30%. Or if it is 22%, you take it as 20%. So make it rounded to the nearest 10% and multiply that burn area with 10. Don't take account of body weight, etc. So if a person has 30% burns, 30 into 10, 300 ml per hour. That is the calculation, which is called the rule of 10. In addition to that, if the patient's body weight is more than 80 kg, you have to add 100 ml for each 10 kg. So for example, if a patient is 90 kg and he has a 30% burn, 30 into 10 will be 300. And for the 10 kg above 80, you add another 100 ml. So it will be 400 ml per hour. That is how you can calculate. So for weight above 80 kg, add 100 ml per every 10 kg. Now we saw about modified Brooks formula, which is used now currently regularly. But what are the older Brooks formula?
Sir, it was 1.5 ml per kg times the percentage burn, sir. Plus 0.5 ml per kg of
It is both crystalloid as well as colloid. That is how it was initially managed. So it is often confused with Evans and Baxter formula. Involves both crystalloid 1.5 ml plus colloid 0.5 ml plus free water. So it is instead of pure colloid, crystalloid of 2 ml, now is given. It was partially crystalloid and partly colloid also. Why do we use lactated ringers for burns patients?
Sir, because it's a balanced isotonic crystalloid solution, sir.
Because of it is fluid recommended by British Burns Association. Osmolality closely resembles body physiological fluids. It contains lactate, which may buffer metabolic acidosis in the early post-burn phase. Okay. Is plasma light the ideal crystalloid for burn resuscitation?
Yes, sir.
Yes. As physiological concentration of sodium chloride, which maintain water and electrolyte balance within the intravascular, interstitial, and intracellular spaces, and does not carry the risk of hyperlactatemia, like in ringer lactate. Prolonged lactate infusion may result in hyperlactatemia, and it is calcium free. So any blood transfusion can be easily given after plasma light. No need to. Whereas with finger lactate, it contains some amount of calcium. So you have to flush it with normal saline and then only give blood transfusion. Whereas plasma light, you can straight away give. And where low magnesium concentration occur following surgery, magnesium will be replaced by plasma light that you give. So this is the plasma light all of you would have seen. What is this 148? And you can see the pH is normal pH of blood or plasma. Why it is called plasma light 148?
Sir, sir, it refers to the sodium concentration, sir.
Sodium and potassium.
Potassium. Okay,
and magnesium. Okay. So 140 sodium, 5 potassium, and 3 magnesium. All together, the cations are 148. That is why it's called 148 plasma. Right. What parameters are used to assess the efficacy of fluid resuscitation, and how to adjust fluid based on these parameters?
Sir, mainly urine output, sir.
Very good. It's based on urine output. So how much of minimum urine you expect or want?
Sir, in adults 0.5 ml per kg.
5 ml per kg per hour. Very good. So
in pediatrics, 1
urine
ml
output
per
of
kg per hour, sir.
0.5 to 1 ml, blood pressure within normal range. These are all the parameters you assess for efficacy. Heart rate variable, central venous pressure 3 to 8 mm, and fractional sodium excretion less than 1%, and bun creatinine ratio more than 20, echocardiograph and ultrasound, normal stroke volume and ejection fraction, base deficit less than 5. All these things are indicative of good fluid resuscitation. And if it is less than 5, you increase fluid. 0.5 to 1 ml per kg per hour, continue the same current fluid. 1 to 2 ml, start reducing the fluid, otherwise you will overload the patient. More than 2 ml, reduce fluid rate by 20%. 1 to 2 ml reduced by 10%, more than 2 ml reduced by 25%. So this is how the fluid adjustment has to be done. How does the pain in burn differ? It's different. How is the pain managed in burns patients? Especially first and second degree burns are very, very painful. So how do you manage?
Sir, pain will be maximum in the partial and
That's why I said first and second degree burn. Already I told you that point. How do you manage that?
Sir,
Right. There are 4 components to pain in burns patient. One is called the background anxiety. The second is background pain. Third is procedural anxiety, and the fourth is procedural pain. Okay. So based on that, acute burn patients who are ventilated, for abolishing the background anxiety, you can give midazolam infusion or dexamethasone infusion and antipsychotics. For background pain, you have to give morphine infusion. For procedural pain, procedural means putting a central line or wound dressing or removal of dead tissue. All these are called procedural. Anxiety will be there in the conscious patient, and procedural pain will also happen. So for procedural anxiety also, you can use the same choice, midazolam or dexmed or haloperidol. And pain is always managed with morphine infusion or boluses. And for acute burn, not ventilated, anxiety treated with dexmed, pain with morphine. And similarly, for chronic acute pain, you can use lorazepam and schedule morphine or methadone for pain component. In my practice, I used to use this combination of ketamine, tramadol, and midazolam. Okay, it's a cocktail. So you take 2 ml of 100 milligram of tramadol, add 2 ml, which again is 100 milligram of ketamine with tramadol, both 100 milligrams, and midazolam 5 milligram in 1 ml. So this will be totally 5 ml. You add 45 ml of saline to that and load it in a syringe pump and give 2 to 3 ml per hour. No, not on the body weight basis, but flatly as 2 to 3 ml per hour. So one cocktail of 50 ml will run for at least, if you give 2 ml, will hold on for 24 hours, that is 1 day. In between, if they want to do any procedure or any dressing change, then you can increase it to 3 to 4 ml. That will give adequate analgesia for the procedure also. At the same time, it will not cause any emergence delirium or other unwanted tachycardia and other things will not happen. What are the reasons for the difficulty in management of pain in burns? Why pain in burns is more difficult? The reasons are there are background pain, breakthrough pain, and procedural pain. So there are 3 types of components in the pain. So background pain is caused by the burns per se. So the burn injury, if it is first degree and second degree, it will cause pain. The breakthrough pain comes from well-controlled background pain, either as an exacerbation of background or originating from another source. So it may be a distant site pain which is breaking through the background. And procedural pain is caused by dressing change, wound excision, line incision, and physiotherapy. And other causes of this pain difficulty in management are patients usually develop hyperalgesia, allodynia, or opioid-induced hyperalgesia. And major burn patients also go into a lot of depression. So all those things make it problematic. So these are all the things about the burns per se. Now coming to the anesthetic management, this again I have classified into managing an acute burns and managing the post-burn sequelae like contracture. So the first question in what are all the challenges in anesthetizing a patient with burns in acute phase? And the wound is very raw and they want to do either a scarectomy, which means removing the necrotic tissue, or doing a major grafting to cover the wound, or apply collagen after washing the wound, which are all very painful in superficial burns. So how do you give anesthesia for such patients?
Sir,
Have you had any experience with that?
Sir, I have taken patients not for acute patients, sir, but maybe older patients for split skin grafting and
Later patients, okay. Then the challenges can be getting an IV access, especially if the limbs and neck are all involved, both the upper limb, lower limb, and neck area. Wherever commonly you secure IV access, that may not be available. And they may develop a tolerance to various drugs because they are given painkillers rapidly, especially the first and second degree. They very soon develop tolerance, so they require more and more dosage. And there may be difficulty in placing the monitors because of the, especially ECG leads cannot be placed if there is a burn on the chest. And the excessive blood loss due to hyperemia may happen. And the use of suxamethonium for intubation is dangerous, which can produce hyperkalemia. Hypothermia, because of large exposed raw areas, they can easily drift into hypothermia. So these are common challenges in anesthetizing a burn acute patient. What is normal maxillofaringeal angle? How is it estimated? And what happens in fixed flexion of the neck? How do you measure the maxillofaringeal angle?
sir, usually more than 100 degrees, sir.
How do you measure it?
It's the angle between the line of along the hot palate and the line along the posterior pharyngeal wall, sir.
Sir, it can be measured by drawing a line parallel to the hard palate, sir.
You have to say that I have to have an X-ray of the head and neck. That is the first answer for that. Okay.
Sir,
So
lateral
this
side.
is the, you have to have a lateral view of the X-ray of the head and neck. So
And
this is called the maxillary angle. Okay, maxillary axis rather. A line drawn along the upper border of the teeth or the palate, or the maxilla. Then a line drawn along the anterior surface of the atlas and the axis, the first two vertebrae. Okay. So normally it is more than 100 degrees in the normal individual where a line neck can be extended. And in a fixed flexion, you can find that this neck will be pulled downwards. So this maxillary and pharyngeal angle, they become less than 90 degrees. That produces the difficulty in positioning the head. That extension what we require is lost. And so the maxillary maxillopharyngeal angle measurement is very important in cases of contractures of the neck. How are the neck scars classified and what is the significance?
So the neck scars are
Okay. So these are linear scars. You can see these are all linear scars which can be classified again into mild, moderate, and severe. They can be band scars. Like a band, it is much more broader and it is a mild, moderate, severe again. And there can be broad scars extending beyond the smaller surface. And again, they can be classified into mild, moderate, and severe. So this classification is important because these linear scars usually the surgeons can manage with infiltration and the Z plastic. Okay, they will divide this and then under local itself it can be managed and they will not produce very severe abnormality in the head and neck position. Whereas the broad scars and the band scars sometimes may cause difficulty, especially this sort of scars which pull the lip down and the neck down. These are the ones which are more difficult to manage. So this classification helps to decide the type of surgery required by the surgeons and for anesthetists it helps to decide how to secure the airway. What are extrajunctional receptors and what is their importance in burn patient?
sir, once if there is a burns means there will be upregulation of the receptors, sir. So more over the synaptic area. So those will be called as the extrajunctional receptors. And the importance is when we give after 24 or 48 hours, the upregulation of these receptors happen, and the moment we give succinylcholine, which is a depolarizing muscle relaxant, it will act at all these receptors and can cause increased potassium release, which can leading to hyperkalemia and cardiac.
Okay. But what is the structural difference between the normal acetylcholine receptors and the extrajunctional receptors? Do they have the same structure or different structure?
No, sir. Extrajunctional receptors are usually immature or fetal kind of receptors, sir.
So which component is different there?
Okay. Sir, gamma. Yeah, gamma.
They differ from junctional receptors. Upregulation due to deficient stimulation of skeletal muscle. They have a shorter half-life than highly sensitive to succinylcholine, open for a longer duration, but ion conductance is smaller and concentrated around the enclaves, but can also be found anywhere on the post-junctional membrane. And they have a similar pentameric structure, that is 2 alpha, 1 beta, and 2 beta and 1 gamma. Here it is the delta subunit is uh, more compared to the epsilon subunit in the adult. Okay, that is the small change that happens in their structure. And dexamethasone from 1 day to 1 year can result in hyperkalemia in these cases. How do burn wounds heal? What are the methods by which the burn wounds heal?
Sir, depends on the
Depth.
Yes, sir. Depends on the depth, sir.
So what terminologies are used?
Sir, healing by reepithelialization, sir, or healing by repair, or healing by skin grafting, or healing by secondary intention, sir.
Healing is usually classified as by restitution or substitution. Okay? So when you say restitution, it is a very, very superficial burn where all the structures like your hair follicles, sweat glands, sebaceous glands, everything will be restored. And it will become normal within 6 months' time. You cannot make out that that skin was burnt earlier. So that is called the restitution, where depth of burn is only up to histologically an area called stratum papillaire. Appendages survive in partial thickness burns like pilosebaceous and sweat glands. And if you see this from the epidermis up to the margin of the dermis, that is called the stratum papillaire. Okay, so that area, papillary zone, that is the first degree burn, it will all come back to normal. So that is called the restitution. Whereas in substitution, what happens? The sequence of events that is happening in any burn injury, first is the hemostasis, then there will be inflammatory process, then proliferation of the cells, and then they will undergo remodeling. So within 1 hour, you will have the hemostasis where platelets, fibrin, fibronectin, glycoprotein, everything, and vasoconstriction will happen in that area. Within 3 days to 2 weeks, there will be inflammation process as well as proliferation process. And 3 weeks to 2 years, you will be having remodeling. So in substitution, what will happen is the depth of burn is more than the papillary area. It goes to the reticular area. In the earlier picture, I showed you that there are 2 zones. One is called the stratum papillaire, and below that is in the epidermis. Below that, you have stratum reticularis. So healing by substitution with unspecialized connective tissue will happen. This is the reason for the scar formation. Okay. So again, you can see in this picture, this is the keratinized standards of squamous epithelium. This is the epidermal ridges. So the whole area is epidermis. Then dermal papillae is there. Dermal epidermal junction is there. Then this is the stratum reticular area. And this reticular area that is destroyed in the burn, that cannot come back to its original level. So that will be replaced by unspecialized connective tissue, and that will form the scar formation. And of course, I will quickly go through these things. This is the cross-linking of collagen. So collagen is the one which forms to strengthen the healing process, and this cross-linking will happen. It will strengthen the scar. And in full thickness, what happens? There will be wound contraction because the wound starts healing from the margin towards the center. So they will pull the normal skin around also, and that is why the contracture occurs. And you can see in this picture, there's a burn injury, there's an inflammatory process, the first stage of hemostasis, and then the inflammation occurs. And you can see the wound is being drawn from the normal area towards the necrotic area or injured area. So the normal skin is also pulled, and that is why you get the shortening, and that results in contracture. So this picture will tell you how this is the raw area, the child with a palmar injury. You can see as the wound heals, it pulls the fingers. The joints are all pulled down, and they have released it and put a graft here. And they have to keep a splint later on to heal the wound. Now, what are the types of post-burn scars? Again, it can be immature or mature scars. So, how to differentiate between an immature and a mature scar? Earlier, what I showed you is the type of neck contracture scars, where you classify them into linear, band, and broad contractures or scars. Whereas generally, any burn scar can be classified into mature and immature. So immature will have a lot of vascular proliferation. So that will look pink and very reddish. Whereas mature scar, all the tissues, collagen would have formed and the vessels disappear. So the color completely changes. Or it can be atrophic and hypertrophic or keloid formation. It can be stable and unstable. It can be depigmented or hyperpigmented. It can be malignant. What is malignant scar is called? Any name for that? With a central ulceration?
Yes, sir. Marjolin ulcer, sir.
Marjolin ulcer. Very good. So that's called the Marjolin ulcer. What are the effects of long-standing contractures? It will affect the deeper tissues also. It will produce shortening of muscles and tendon. It may dislocate the joints also. And bony deformity also can happen in a growing children. So why should contracture release surgery be done? When should the contracture release surgery be done? It should not be done during the acute phase of the healing. Okay, excessive bleeding will happen, and the failure of graft take will happen if there is a intraoperative hemorrhage, and it may result in more vigorous contracture postoperatively. And initial stages of any contracture is amenable to physiotherapy because it has not formed collagen and does not become strong. So if you apply a splint and give regular physiotherapy, you may avoid a contracting scar. So you should not operate on an immature healing scar. When you operate on a healed mature scar, the advantages are you are less bleeding, it will be soft and supple. You can identify the plane easily and remove that the scar alone. It will be avascular, hence less bleeding. And the challenges in contracture of the neck scar with a fixed flexion. This is the case scenario that we have given. So how do you manage, or what are all the things you anticipate in this case? Here we have a 7-year-old boy with a fixed flexion deformity of the neck, contracture neck. Will you cooperate for local anesthesia release?
So since it's a pediatric child, maybe we can start with some ketamine, or if we secure a Venflon, then some ketamine, and if it's a difficult area, then local infiltration and contracture release has to be done prior to airway manipulation, sir.
Otherwise, supposing surgeon is not willing, he says if he gets infected, he is not cooperative. Surgeon is not cooperative, as well as the patient.
So then airway, sir. So it's going to be in induction with sevoflurane with maintenance of the patent airway and trying to secure the airway, sir.
Secure the airway by what?
Sir, endotracheal tube, sir. Fiber optic.
Instrument that you are going to use is fiber optic. So awake fiber optic or asleep fiber optic. These are the two options for securing a difficult airway. Okay. So
yes,
the challenges are there is a difficult airway, there is likely to be blood loss, there is likely to be difficulty in positioning the patient if he is in acute contracted state. They can go for hypothermia and post-operative pain, and we have to immobilize their neck if you are applying a graft to prevent the graft getting dislodged. These are all the challenges in the management of a neck contracture. But to secure the airway in a neck contracture, the options are you have awake fiber optic intubation, which is not possible in a 7-year-old child. He is not likely to cooperate. Second is asleep fiber optic intubation. So you can induce some anesthesia and try to intubate the patient using a fiber optic scope. Then release the contracture under ketamine, as you said, as the first option, followed by intubation. Then release the whole thing under tumescent anesthesia. If supposing the patient is very cooperative and understanding, you can get the rapport and we can release it. So these are the 4 options: awake fiber optic, asleep fiber optic, contracture release under ketamine, and release under tumescent local anesthesia. Now, how do you do asleep fiber optic intubation? Have you ever done any cases like this?
Not in a pediatric child, sir, but adults, yes, sir.
So the same thing holds good for pediatric also, if you have done in adult.
Yes, sir.
Can you describe the steps in asleep fiber optic intubation?
Sir, in describing for this child, first I tried to secure an IV line, sir. If an IV line is not there, then I'll induce the baby with 100% oxygen and sevoflurane. Try to secure an IV line. Give some vitamin and Dexmed infusion or some amount of propofol for sedation. And making the baby airways like the respiration spontaneous. I'll try to put the pediatric fiber optic bronchoscope. Also, I'll use the spray as you go technique. And prior to this, I need to, if possible, we could have given some nebulization. But if the baby is not cooperative, then we can provide some local lignocaine spray as we go through the trachea. And once we are through the into the trachea, then we can negotiate the endotracheal tube through it and connect to the ventilator, sir.
Okay. What about the monitors?
Sir, ASA standard monitors.
Exam, you must always remember that you have to say about the safety. Okay, first and foremost, you have to say that I will connect all the monitors. Okay, of course, what you are saying is from your practical experience of what you have done. But for exam, there is a pattern of what you have to follow. Okay, otherwise the examiner will think, "What man, you are not safe at all. How do you know the patient is not desaturating?" So that is how they will try to corner you. You connect all monitors. Have help of an experienced second anesthetist. This is the second one. Ensure oxygenation at all times. This is how you manage the answers in your exam. Okay, even though you may be doing it repeatedly in your practice, but the exam you have to present it in a proper order. So, induce sleep with titrated doses of propofol and remifentanil. Spray and anesthetize airway with local anesthetic 4 or 10% lignocaine. Proceed with fiber optic intubation, preserving the breath spontaneous respiration. That is a very, very important point you should highlight in your answer in the examination. Never paralyze a difficult airway patient. That is the dictum which the examiners expect from you. So all the time preserve spontaneous respiration. Placement of an oral airway or LMA may help to maintain patency in the help in intubation. So airway secured under ketamine anesthesia is only suitable in cases where mask ventilation is possible. So if at all you are able to hold the mask and induce anesthesia by inhalation induction, then in such cases, you have to have a prior discussion with the surgeon about the need for this, and securing his cooperation is very, very essential. Then induce anesthesia with inhalation agent face mask and give ketamine 0.5 to 1 milligram per kg IV. Then surgeon should quickly release the contracture adequate for laryngoscopy and intubation. Okay? Once that release is done, perform a trial scopy to assess the ease of intubation. Spray the vocal cord with 4% xylocaine. Intubate and proceed with surgery under spontaneous or controlled ventilation as it may require. So I'm showing a few. This is an adult patient. This is not a 7-year-old, but you can do the same thing for a 7-year-old also. So induce with inhalation induction agent, give IT ketamine. Then you can see the surgeon is already made a transverse cut in the scar, and he is now manually separating the scar to extend the neck. And once the manual separation is done and adequate extension is achieved, we can put a scope and try to intubate the patient, successfully intubate. So this is how the sequence of events happen in ketamine intubation. Now, what is tumescent local anesthesia?
Sir, it's the
Why it is called tumescent? What is the meaning of the word tumescent?
sir, this is like a longer acting local anesthesia, like BP, liver, like we give a large amount of local anesthetic in that area, and it will
Tumescent means swelling. The word tumescent means swelling simply. And tumescent local anesthesia is injecting large volumes of dilute local anesthetic solution. It's called tumescent local anesthesia. The composition can be normal saline, lignocaine 1% 50 ml, epinephrine 1 in 1000 1 ml, and sodium bicarbonate 12.5 ml. This is one composition. The other one, this is supposed to be slightly irritable in injecting. When you inject, it may cause a slight of irritation. To avoid that, you can use ringer lactate and the same amount of lignocaine and epinephrine. And without sodium bicarbonate, you can get less pain during injection. And what are the advantages of tumescent local anesthesia?
sir, it can prolong the anesthesia effects.
It provide excellent analgesia, sir. It produces marked, reduces blood losses, sir. It gives a prolonged pain relief, and
Okay, right. So large volume can be injected to cover large area. Excellent hemostasis because of the dilute epinephrine producing vasoconstriction, and causes hydrodissection of the scar. It helps the surgeon to excise the scar easily, and cause you can assess the extent of release if you are doing it under pure tumescent anesthesia. Especially, you can do it for adult cases. You can do the contracture release with tumescent itself. At that time, you can see, ask the patient to move the head and look up, and you can see how much of extension has been achieved. And it causes less infection because of the bacteriostatic property of lignocaine, and it helps in very good graft uptake because there is no blood loss or hematoma in the field. The contact with the graft and the raw area will be very good, and the graft take will be almost 100%. Any complications of local anesthesia, tumescent local anesthesia?
Sir, overdose, sir. Like
Volume load can
volume.
result in overhydration, pulmonary edema in cardiac patients. Lignocaine can cause conduction blocks to produce bradycardia. Epinephrine can cause some arrhythmias, and delayed bleeding from the operated wound after the effect of epinephrine wears off. Sometimes that can produce a hematoma. And requirement will be there for harvesting the skin graft. If you are doing a contracture release of the neck under tumescent alone, then you may have to substitute some other form of anesthesia for harvesting the graft from the thigh or other area. Okay. What are the three upper airway lifelines when you are managing a difficult airway? Because the questions can also be asked on the difficult airway management because it's an anticipated difficult airway. What are the three upper airway lifelines which are used?
Face mask, sir.
Face mask, very good. Then
LMA, sir.
LMA,
Intraglottic airway devices and
endotracheal. Okay, so these are the three things: face mask, LMA, or endotracheal tube. These are all the adjuncts that you have to use for that. And what is Lemon law or Lemon assessment of airway?
Sir, it's airway assessment tool, sir. With this acronym of LEMON, L stands for to look externally for any abnormalities, sir, like micrognathia or a facial asymmetry. And E is for to evaluate the airway, like mouth opening and hyomental distance and thyroid distance. These things has to be evaluated, sir. And based on a 332 rule, and M is for Mallampati classification, 1, 2, 3, 4, and O is for any if obesity or if the chances of obstruction, like any tumors or uh, any physical restriction is there, like scar or anything, and N is for neck mobility, sir.
Mobility. Okay, so this is how the whole thing is called Lemon. And this is the 332 rule. This is for the juniors who have not had any exposure to this type of cases. So the Lemon evaluation is 3 through, which is our distance, that is mouth opening, hyomental distance, and thyromouth mental distance, thyroid distance actually. So you use the fingers this way to assess the opening. And how to prepare yourself for a difficult airway management. For all the preparations you have to do.
Sir, the difficult airway cart has to be prepared, sir. In the OT, difficult airway cart has to be ready.
Okay, first take a history, then evaluate the patient, have a good planning, then preparation of other staff to help you, and preparation of the equipment. Under equipment comes all the preparation of difficult airway cart, front of the casket kit, all these things. Okay, these are the 5 steps in the difficult airway. What is peri or para intubation oxygenation? Earlier days, this was not there during our postgraduate years, and up to I remember 1995, we used to struggle. We used to induce, and then if you are not able to intubate, patient will desaturate, the monitor will start yelling, and then we again apply the mask and hurriedly ventilate. To avoid all these things, now they have introduced this concept of peri or para oxygenation, where originally recommended for rapid sequence induction, and it is based on the apneic oxygenation technique. When a patient is paralyzed and not breathing, the way how you oxygenate them is now advocated for difficult airway cases also. So there are 4 methods. One is called the high flow oxygen of 15 liters via nasal cannula, which is called no desat. That is, patient will not desaturate. Then the thrive is there. Then there is a buccal oxygen delivery method. So what is the mechanism of apneic oxygenation? How does it happen when the patient is not breathing?
Sir, apneic oxygenation is we give high flow oxygen, sir. High flow oxygen or we give through nasal cannula. We give at 15 liters. We keep the nasal cannula and we keep the patient, sir. So even if the patient is not breathing, due to the partial pressure difference, there will be diffusion of oxygen through the lungs to the organs, sir, bloodstream, sir.
So the answer you have to give correctly is, now when you give continuous flow of oxygen, 15 liters, the entire dead space of the patient which consists of the nose, pharynx, up to the trachea, everything is converted into oxygen. It is all replaced. The air in the area is converted or replaced with oxygen. Okay, and the oxygen which has reached the lung is being taken up constantly by the circulation that is coming there. So when the oxygen is drawn in, the volume of carbon dioxide coming out is not matching that oxygen volume that is going in. So there is a negative pressure created. So this will pull the oxygen that is available in the dead space or the pharynx and the other areas. Okay, that is the main description that you have to give.
Okay, sir.
Mechanics are pressure difference between oxygen diffusion from the alveoli and carbon dioxide excretion from the capillary generates a negative pressure gradient resulting in what is called aventilatory mass flow. This terminology you have to use in your answer. Aventilatory mass flow of gases into lungs. So insufflation of oxygen into the pharynx via nasopharyngeal catheter. So there is a continuous flow which will push that mass of oxygen, okay, because it is continuously flowing. And so even if the patient is apneic, this negative pressure created at the alveolar level will drive the oxygen towards the alveoli and maintain the oxygenation. That is the method. So the no desat method, this is the technique. You first put a nasal cannula. You can see the nasal cannula being, what is it? So this is the nasal cannula which is there, over which you have a transparent mask which you can see. So you give 15 liters of oxygen through that and ventilate this patient. And this is the Thrive equipment where you can give up to 60 to 70 liters of oxygen, which will the expansion for Thrive, all of you know that it is the transnasal humidified respiratory ventilatory method. That is the expansion of that. And in buccal oxygenation, what you do is you take a 3.5 mm oral ring RAE tube and cut the bevel end with a Murphy side. And then remove this adapter also and insert the oxygen source tubing to the cut end and insert this to the side into the buccal cavity of the patient and start giving a high flow of oxygen. And this will reach the, instead of putting it in the nasal cannula, you can put it in the oral also, which is called the modified buccal oxygenation. What are the various degrees of mask ventilation? Can it be classified? Your ability to mask ventilate. I'll just go through faster because we are running out of time. Natural airway, it can be or easy with a chin lift, and it can be one person with a jaw thrust needed for a good seat of mask, or it can be one person jaw thrust with a oral or nasal airway, or it should be two persons, one holding the mask and giving a jaw thrust and other ventilating, and impossible to gas exchange. These are all the various grades of severity of mask ventilation. So one person called Hans, who have classified this mask ventilation score. So if the ventilation by mask is very easy, this is grade 1, which is 71.3%. With the oral airway, with or without muscle relaxation, it can be 26.3. And difficult ventilation, even with two providers, is very rare. And unable to mask ventilate forms only 0.15%. And the technique of holding the mask, what do you call this particular technique? Which is the normal way you hold your mask?
CNE technique, sir.
ENC clamp method, very good. And what is this method called?
CNE.
Two-handed mask ventilation.
Two-handed grip, very good. So what conditions cause difficult mask ventilation? Which conditions cause difficult mask ventilation?
Tongue falling, sir.
It can be inadequate mask fit, like in bearded face, edentulous patient, obese, short neck, elderly, or it can be inadequate patency, have a snoring habit, have a stiff lung or OSA, What is the mnemonic for difficult back mask ventilation?
Moon, sir.
Moans. Mask C is not possible. Obesity, age more than 55, no teeth, stiff lung. Okay, this is it. What is the intubation difficulty scale? IDS. So it can be classified as number of intubation attempts, then number of involved anesthesiologists, more than one, number of alternate techniques, and the Cormac-Lahan grade, required lifting of force, and required laryngeal pressure, and vocal cord mobility. All these things are taken into that. And if a score is more than 5, it indicates the difficult airway. And what is the mnemonic for difficult supraglottic airway device placement? It's called RODS. Restricted mouth opening, obstructed upper airway, distorted or disrupted airway, stiff spine or lungs. How to decide if supposing you land up in a situation of cannot ventilate, cannot intubate. Now cannot intubate is changed to what is the current change in this?
Cannot oxygenate.
Oxygenate, CVCO. CVCA is become CVCO. So how to decide in cases of this?
Sir,
if surgery is imminent, proceed under regional anesthesia or create a surgical airway. Okay, two simple suggestions. And if surgery can be postponed, abandon anesthesia and surgery and wake up the patient. Okay, these are the two decisions that you have to make. So any life-threatening surgery which has to go, you proceed under regional or create a surgical airway and ventilate. If surgery is not that urgent, you abandon and wake up the patient. What are the causes of difficult front of neck airway access?
Is there any burn scar?
Any mnemonic for that?
Yes, sir.
It's called SHORT. Okay, scarred neck, hematoma, obesity, obscuring landmarks, radiation to the neck, and trauma or tumor. Okay, and what is this shown here?
Sir, what is?
What is this picture shows? What is it called?
Laryngeal shake.
Levitan's laryngeal handshake. Okay, it is called Levitan's laryngeal handshake. And to identify the cricothyroid membrane for emergency cricothyroidectomy. So you start from feeling the hyoid bone, come down to feel the thyroid cartilage, and then come down to feel the cricoid. And once you feel the thyroid and cricoid, you put your finger to identify the gap between that to identify the cricothyroid membrane. What is shown here?
Sir, serial dilation technique, sir.
This needle cricothyroidectomy. Okay, just put in the needle, aspirate with to see whether air is coming, and then use this for ventilation. What is this arrangement?
Jet ventilation.
This is an emergency assembly for ventilating through a cannula in the when you do a needle cricothyroidectomy. What are the methods of confirming proper placement of endotracheal tube?
Sir, ETCO2, sir. Gold standard.
How many? ETCO2 number or graph?
ETCO2 for number, but for at least 3 consecutive, more than 3 consecutive.
Six graphs should be seen. Okay, 6 proper ETCO2 graphs consecutively. If you see 6 consecutive Cashno tracings, that is considered as a this thing. Second is putting a fiber optic scope, gold standard. Inspection with the fiber optic scope. How to extubate a patient who have been successfully intubated in a case of difficult airway? Can you just like that pull out the tube after the surgery is over?
No, sir. Until
For
the patient
example,
completely awake and obeys commands.
leave the tube till there is a satisfactory recovery, or leave a tube exchanger and then remove the tube. And 543 formula, which is formed by me, gave a talk on difficult airway management. The 5 points to be checked before intubation are mouth opening, mandible protrusion, neck extension, Malambati grading, and thyromental distance. The 4 points to avoid complications are maintain your oxygenation at all times, avoid trauma, have a backup plan, call for help early. And 3 decisions to be made before induction, whether to use awake intubation or not, whether to use percutaneous technique of front of neck access, whether to preserve spontaneous ventilation, or you can safely paralyze the patient. Okay? Now identify the equipment shown here.
Video LMA, sir.
Video LMA. The total track video laryngeal mask. So this is called total track video laryngeal mask. So laryngeal mask used with a video camera. Right. What is this? Like this is called the Levitan FPS optical stillet inserted into a single lumen tracheal tube. Okay. So this is called the optical stillet. Produces a light there. And it is used. So that's all for the night. And any doubts on that?
No, sir.
No, sir.
Shall we sign off then?
Thank you so much, sir.
Thank you.
Thank you, students. Can we sign off today's meeting, sir?
Yeah. Wish you all a very happy New Year, because we will be meeting only after the New Year. So wish you all good luck and all success.
Thank you, sir.
Thank you, sir. Happy New
Happy
Year
New
to
Year,
sir.
sir. Happy New Year,
all,
sir.
Happy
Thank
New Year.
you. Thank you. Thank you.
Good night, sir.
Good
Good night,
night.
students.
Thank you, sir.
Thank you, sir.
Thank you.